My name is Maria Paula Alvarez Messias, and my topic is Echinococcal cysts in the liver. Definition: Cystic echinococcus is a complex, chronic and neglected disease with a worldwide distribution. The liver is the most frequent location of parasitic cysts. In humans, its clinical spectrum ranges from asymptomatic infection to severe, potentially fatal disease.
Is a fluid-filled cavity in the liver. Usually liver cysts are not cancerous and not even dangerous. When you have a liver cyst, you often don't even know it. Most of the time there are no signs or symptoms. That said, larger than average cysts can sometimes be felt if you press down on your abdomen. Very large cysts may rupture or push against other organs, causing bloating, a feeling of fullness, and a sudden pain in the upper right abdominal region. Liver cysts don't typically affect function. They can only be detected on ultrasound or CT scans. When needed, treatment may include drainage or removal of the cyst. Only rarely might liver cysts indicate a serious underlying condition such as polycystic liver disease, an inherited disorder, Echinococcus infection caused by a certain type of parasite, liver cancer. The cause of simple liver cysts is unknown, but they may result from a malformation present at birth. Liver cysts are found in about 1% of adults and are more common in women than in men.
Application in medicine. Four approaches exist in the clinical management of cystic echinococcus surgery: percutaneous techniques and drugs, treatment for active cysts, and the wash and weigh approach for inactive cysts. Allocation of patients to this treatment should be based on cyst stage, size and location, available clinical expertise, and comorbidities. However, clinical decision algorithms, efficacy, relapse rates, and cost have never been properly analyzed. This paper reviews recent advances in classification and diagnostics, and the currently available evidence for clinical decision-making in cyst echinococcus of the liver. Symptoms: abdominal discomfort and pain, obstruction jaundice, anorexia, incontinence, and obstruction of bowel ducts.
Hydatid disease is diagnosed with a combination of radiographic imaging and serologic testing. Ultrasound is widely utilized to screen for hydatid disease given its accessibility, ease of use, and relatively low cost. As a diagnostic modality, it has high sensitivity ranging from 90 to 95%, but its specificity is lower given that it can be difficult to distinguish hydatid cysts from benign cysts, abscesses, and neoplasm. However, presence of, quote, hydatid sand, the visualization of the protoscolices within the cysts, would certainly clinch the diagnosis. CT is a study of choice for hydatid disease. Not only does it have higher sensitivity ranging from 95 to 100% compared to ultrasound, but it is also better able to determine the size, number, and location of the cysts. If the etiology of cysts seen on radiographic imaging is uncertain, serologic testing for Echinococcal can confirm the diagnosis. ELISA can detect the presence of antibodies against Echinococcal with both high sensitivity of 94% and specificity of 99%. Based on radiographic imaging, the WHO classification system divides hydatid cysts into 6 different stages to help guide treatment. WHO stage Cystic echinococcosis 1, or CE1, is a unilocular cyst, while cystic echinococcus 2, or CE2, is a multiseptated cyst with daughter cysts. Both of these stages are considered early stages when the parasites are active. WHO stage cystic echinococcosis CA, or CE3A, and cystic echinococcosis CB, or CE3B, represent cysts with detached membranes and daughter cysts, respectively. These stages are transitional ones between live and dead cysts. WHO stage cystic echinococcosis 4, or CE4, is a cyst with heterogeneous contents, while cystic echinococcosis 5, or CE5, is a solid cyst with a calcified wall. Both of these stages represent dead cysts. This CT image demonstrates a WHO stage CE1 hydatid cyst that is unilocular with an absence of daughter cysts. CT image in the upper left corner shows a WHO stage CE2 cyst that is multiseptated with daughter cysts, as indicated by the arrow. The plain radiographic image in the lower right corner demonstrates WHO stage CE5 dead cysts with calcified walls in the liver. These images demonstrate hydatid cysts in the lung, shown here on the left, and in the brain, shown on the right.
Pros and cons. Pros. Most cysts in the liver do not produce this and maintain and balance the aging at the host. It takes many years to affect the organs, and the most are the inactive states, so the treatment is easier than the pulmonary. Cons. Cysts echinococcus can go undetected for many years due to the slow growth and the development of cysts and the response of the young immune system. Depending on the size and location, cysts can eventually exert pressure on the nearby structure, producing abdominal discomfort and pain.
Treatment of hydatid disease is based on disease stage and cyst size. For inactive cysts, or CE4 through 5, no treatment is necessary and only observation is warranted. For active and transitional cysts without daughter cysts, or CE1 and CE3A, treatment is dependent on the cyst size. Albendazole alone is the only therapy required for cysts under 5 centimeters, while albendazole with puncture, aspiration, injection, and reaspiration, or PAIR, is necessary for cysts greater than 5 centimeters. Albendazole is dosed 10 to 15 milligrams per kilogram per day in 2 divided doses for 1 to 6 months depending on treatment response. PAIR is a percutaneous intervention where the cyst is punctured under ultrasound or CT guidance, its contents aspirated, then injected with a protoscholicidal agent such as 30% saline or 95% ethanol, and reaspirated. This process of injection and reaspiration is repeated until no protoscholices are present in the contents of the cyst. PAIR has a greater than 95% cure rate in hydatid disease without daughter cysts. For active and transitional disease with daughter cysts, or CE2 and CE3B, treatment involves a combination of albendazole and either modified catheterization or surgery. Modified catheterization is a percutaneous intervention whereby the mother and daughter cysts are removed using a combination of drainage large catheters and aspiration devices. The image on the right demonstrates the surgical resection of a large mother and multiple daughter cysts from the kidney, and the left photo shows multiple resected hydatid cysts.
Issue applied in Ecuador. 2008, it was determined that there is a lack in information on the disease in Ecuador. The greater prevalence of Cysts echinococcus in human and animal hosts is found in countries in the temperate zones, including southern and South America, the intra-Mediterranean littoral, Central Asia, China, Australia, and parts of Africa. In the USA, most infections are diagnosed in immigrants from countries in which Echinococcal disease is the cyclic endemic.
Echinococcal infection is distributed in South America, Europe, southern and central Russia, Central Asia, Australia, and Africa. The risk of infection is highly influenced by the extent and nature of human association with dogs. The parasite is widely prevalent in regions of the world where dogs are used to care for large flocks of sheep. This map illustrates the global distribution of both echinococcal species, with E. granulosus represented by regions marked in black and E. multilocularis marked with an X. The relationship between Echinococcus and its intermediate and definitive hosts is relatively straightforward. Adult worms inhabiting the small intestine of the definitive hosts release eggs in the stool. These eggs are then ingested via fecal-oral transmission by the intermediate hosts, allowing for the eggs to hatch and larvae to penetrate the intestinal wall. Once inside, the larvae are taken up in the bloodstream and distributed to the liver, lungs, and other organs, where they form hydatid cysts that enlarge slowly over time. Definitive hosts become infected when they ingest these cysts, for example, a dog consuming the infected viscera of a sheep, allowing for immature protoscolices from the cyst to attach to the small intestine of the definitive host and mature into adult worms, completing the life cycle. Hydatid cysts are composed of 3 layers. The pericyst is the outer layer, consisting of modified host cells, fibroblasts, giant cells, and eosinophils, which together form a rigid protective layer and represents the host response to the parasite. The exocyst is the middle laminated membrane of parasitic origin, permitting the passage of nutrients from the host to the parasite. Disruption of this membrane predisposes the cell to degeneration, death, and bacterial infection. The endocyst is the inner germinal layer. Immature protoscolices multiply within outpouchings of the germinal layer, known as broad capsules. Daughter cysts, smaller hydatid cysts derived from the primary mother cyst, may also develop within the endocyst. This photo shows the typical appearance of the laminating membrane of a hydatid cyst which has been removed surgically.
Conclusion: Hepatic Echinococcus cysts, outlet fading or common in North America, should be considered in the different diagnostic and hepatic cysts, particularly in pains with sporous risk, such those he has traveled to the emigrate from a real in the prevalence.
Prevention of Echinococcal is focused on disrupting the life cycle of the parasite. With respect to the definitive host, treatment of dogs with praziquantel has been shown to be an effective strategy. Additionally, adequate disposal facilities at slaughterhouses to prevent consumption of infected sheep viscera by dogs and minimizing the amount of stray dogs in endemic areas are important control measures that can be taken. With respect to the intermediate host, vaccination programs involving sheep and cattle against Echinococcal have been implemented with excellent results. Lastly, with respect to humans, washing fresh produce carefully and avoiding close contact with dogs can prevent accidental fecal-oral transmission of the parasite.